Amazing. Okay. Well, I will introduce our guests. We're so lucky to have Dr. Messer and Linda Kenney Baden here with us this evening. Dr. Messer is the most fabulous endocrinologist in all of Manhattan, and we're so thrilled to have her here to talk to us about GLP-1s and Ozempic and all of the questions that we all would love to have more conversations about, but don't seem to be able to. And I know that we will really value the information that we're getting here tonight. So I can't thank you enough. And Linda, you will be the interviewer, which will be fabulous because I know you're longtime friends and all the things. And so I'm excited to hear you both in conversation. Thanks for spending this time with us. We really appreciate it.
Thanks, Judy.
You're terrific. Thank you very much. Hi, I'm Linda Kenney Baden. I'm a lawyer by trade. And the only thing, Dr. Messer and I have two things in common. One, she was on jury duty a couple weeks ago. So she got to see what I do. And the second thing is I'm a patient of hers. And I'm proud to announce that I'm not Lizzo, who's going to deny and be accused of having allegations of not being on a GLP. I've been a patient of Dr. Messer's for about 1.5 years. And the reason why I'm here from her is because my doctor, Dr. Wendy Zychek, who's an internist, a fabulous internist, said you have to go to the most fabulous doctor in New York that does this, who is an endocrinologist. So she has a motto, listen to the patient. You can go to her page on the Well Centers, Well by Messer. She is board certified. And for those of you who don't know what that means that somebody else higher up, there's like 20 specialties, I think, in medicine or something about that. And that means that she's taken exams and recertified and all. She's not just a black market, somebody giving out drugs. She's a true doctor and a fabulous one at that. Now, the reason why I'm interviewing her is because I've been in TV a while. And also, I'm a success story. I lost about 70 pounds, I think it is, Dr. Messer, when we talk, over the last 17 months, using GLP, I use Mounjaro, if you've been using Mounjaro. I've had a commitment to working with Dr. Messer, to doing it right, to eating right, to exercising right. And it's because for 10 years, I just couldn't lose an ounce. No matter what I did, I was like on a water diet and couldn't lose an ounce. So here we are. I want to bring in Dr. Messer, and I'm going to first ask her that we've heard so much about brand names, Ozempic, Wegovy, Mounjaro, Zepbound. They are GLPs, semaglutides. What actually are they? What does that mean, and where did they come from?
Great question. All right, Amy, can we cue up the first slide? All right, so we toss around this term called incretins a lot, and I don't honestly think most doctors even understand where the word incretin came from. Incretin is sort of like an umbrella term for a lot of these medications that we talk about. So semaglutide and tirzepatide, those are the two that are probably most popular these days. I'll get into that more, but it actually stands for, the IN comes from intestine, secretion of insulin, because these hormones, and that's what they are, they're secreted by a portion of the intestine. So it was first coined actually in 1932. So we've known about these for a long time. They're gut hormones that stimulate the pancreas to release insulin. And so that's where the term comes from. Next slide, please. So the incretin is this mysterious effect. So this is kind of a complicated slide, but I wanted to treat everybody like they're sort of clinician scientists today and just get into the details just for a moment. So when you get glucose through an IV, not a lot of insulin is secreted from the pancreas. But suddenly when we give that exact same amount of glucose, and glucose is just sugar, through an oral bolus, so you have somebody swallow the sugar, all of a sudden you can see this really steep increase. So C-peptide is like basically saying the same thing as insulin. You can see this huge increase in insulin. And the question is, why is that? And so we just thought, this is a mystery, this is a miracle, we don't really know what this is. And then lo and behold, we discovered that it's something called the incretin. So next slide, please. So I invited my dad to be on this call. I'm not sure if he's here. One, because he likes to see me talk, but also because it was his friend. My dad is a researcher, a doctor at the Bronx VA hospital. His friend, Dr. Eng, actually helped discover incretin. So there's this monster called the Gila monster that can be found around the world. And in the saliva of the Gila monster is actually these hormones, incretins. And so the legend goes, although I think it's really true, that Dr. Eng was bitten by a Gila monster, lost his appetite, and somehow was, because he was a scientist, was able to isolate what it was in the saliva that was causing his lack of appetite. And that was this incretin molecule. So let's do the next slide. Okay, so people say to me all the time, well, incretins were just discovered. And so once again, just to be clear what an incretin is, we know about the GLP-1s, that's all these medications that everybody's been on that have become really popular. It also includes something called GIP, which is also found in Mounjaro and Zepbound. And then there are new ones that we're going to be putting into medications within a year or so called glucagon receptors. But basically this whole class of intestinal hormones that have a variety of effects, and I'm going to talk about in a moment. But the revolution really began a long time ago. The first medication on the market was called Byetta, and shortly afterwards Bydureon. And I thought this was so cutting edge. I was so excited by it when I was training. That's when these first came out. I really didn't understand them very well, but I thought it was very exciting. They're like dinosaurs now, but we were using these medications, endocrinologists who are in the know, even back then for weight loss. Back then, it was so easy to get insurance to cover it. You really didn't have to say anything, and you would get a prescription for your patients. Way before the Kardashians got wind of this, we were using them basically on everybody with polycystic ovary syndrome, everybody who needed to lose weight. I thought of a million off-label uses, but these were FDA approved for diabetes. So we'll do the next slide. Actually, Linda, do you want to?
Yeah, that's just, so now that I've heard that, and I love the Gila monster story about he was bitten and lost his appetite. I think I would lose my appetite just by being bitten, but that's okay. It's great. But yeah, so now that we know what they are, how do they work on the system, and what do different ones work differently?
Okay, sure. So that does get to be a bit of a complicated story, and I don't want to lose my audience here. There are so many different things that it does. So the main effect is clearly that they tell the pancreas to produce insulin when the blood sugars are high. Now, the question I get asked a lot is, okay, well, I don't have diabetes. My sugars aren't high. Am I going to develop low blood sugars? Is this dangerous? And the answer is categorically no. It's this incredible hormone that developed over millions of years of evolution, and it only tells the pancreas to produce insulin if blood sugars are high. So if you happen to be lucky enough to have normal blood sugars, that particular effect won't happen. But there are so many other things that it does. It slows down the passage of food through the gut. We call it gastroparesis. I remember a few months ago, it started coming out in all these articles and Wall Street Journal. Oh my goodness, it can cause gastroparesis. We're like, yeah, that's kind of the point. It makes you feel full. So we like that it causes that. So you get this physical feeling of fullness, but it also works in the brain. So it crosses the blood-brain barrier, and in the hypothalamus, which is a part of the brain, you have two nuclei, one that controls this sense of well-being, which is different from feeling full, so a sense of satiety. And then in another nucleus, you feel full. So it's doing all of this in tandem. And this is honestly just tip of the iceberg, but those are some of the things that the GLP-1s do. And honestly, the GIPs as well. The GIPs have some extra effects that the GLP-1s don't have, which is probably why in clinical trials, which I'll get to in a moment, the tirzepatide, which is, for example, Mounjaro and Zepbound, tirzepatide might work a little bit better. It has a direct effect on sensitizing patients to insulin, the hormone that causes blood sugars to drop. And it also probably has a direct effect on fat burning. So GLP-1s don't have that effect, GIPs do.
That's really really interesting. So you're telling us how they work. You're telling us there's a little bit of a difference in them because of the Ozempic versus the Mounjaro. But where do you start the patient, and how do you decide what a patient is going to be on? Where do you start? How is a drug, really three questions. How is a drug administered? And how do you determine dosages?
Great question. Okay, so these are the FDA approved injectable weight loss medications. So Saxenda is sort of a dinosaur as well, an oldie but goodie. Sometimes when you can't get anything else covered by insurance, that's what we do. But it's certainly pretty inferior in terms of weight loss. So we try not to give that unless we really have to. It's also a daily injection. So then the choice becomes, are we going to give Wegovy or are we going to give Zepbound? So I will say Zepbound doesn't have the cardiovascular indication yet, to decrease the risk of stroke, heart attack, and death. Wegovy does. I believe that it's a class effect and Zepbound will have that cardiovascular indication at some point. It's really sometimes comes down to how much weight I want them to lose. So if somebody doesn't have a lot of weight to lose, Wegovy is a perfectly reasonable option in my mind. If they really want to lose 60 pounds, real weight loss, then we're talking about medications like Zepbound. So just to clarify this, because I know this can get so confusing for the audience, Zepbound is 100% identical to Mounjaro. It's made by Eli Lilly. You literally just change the sticker, the label. So there is nothing different. And Wegovy is 100% identical to Ozempic. So the only reason they renamed it and relabeled it is that they could get it FDA approved for weight loss as opposed to diabetes, but we're talking about the exact same thing. So in terms of dosing, so we always start on the lowest dose and then gently, slowly increase the dose. We don't like to go too quickly. Usually, so Saxenda actually you can ramp up weekly, but the Wegovy and the Zepbound you ramp up monthly. You don't have to get to the highest dose, which is technically considered the maintenance dose. And that's sort of part of the art of medicine. You work with the patient, you see what their side effects are, you see where their weight is, and you can stop at a lower dose if that's the dose that's working for them. And then that can become their maintenance dose. Or even you can get them to their ideal body weight and then start slowly pulling back on the dose. And by the way, all of this is off label, but it's what most endocrinologists do. And then you can even almost like microdose these medications and start increasing the interval between doses. So a lot of my patients required, let's say, Zepbound, the full dose, which was 15 milligrams, then they were able to pull back on it and maybe just take 2.5 milligrams once a month just to help maintain the weight loss. So a lot of it is trial and error. There's no one set answer, but you do want to be working with your doctor pretty closely to figure out what works best for you.
Okay, so that led me to one of the later questions I have, but lead into it. The maintenance dose is really trial and error, and that's why you have to have a doctor like you, Dr. Messer, who knows what you're doing and can listen to the patient and see what the patient needs. I know I went from 25 to 5 to 75 to 12.5 because it all of a sudden seemed to me that you get to have a plateau. Is that plateau something that is known, or is that patient specific?
Yeah.
Then with that, let me give you one more, A, that was A and B, because you know how I like to do this. C, what are the side effects? Because you mentioned people have side effects.
Okay, perfect. So I would say that each dose only helps with a certain amount of weight. So nobody keeps on losing weight indefinitely on a single dose. And so once a patient has plateaued, I will typically ramp up the dose. And that's assuming that the patient is actually working with a dietitian and exercising and all of that. If I don't feel like the lifestyle has changed at all, maybe I'll try to change the lifestyle before increasing the dose, especially if they're having side effects. But yes, there is a max amount of weight loss, I would say, on each medication, on each dose of the medication. In terms of side effects, most of them are pretty non-catastrophic and they're gastrointestinal. What's interesting is if you look on the package insert, they talk about diarrhea all the time. Sorry if anybody's eating dinner and listening to this, but really the vast majority of patients are getting constipated. And if they are getting diarrhea, it tends to be a reaction to having been constipated for too long. So we call it like overflow diarrhea. It sort of builds up behind it. And occasionally there can be something called bacterial overgrowth when patients are on medications for a really long time. And then they can experience diarrhea, but mostly it's constipation. And I'll get to this later, but that's we can use that to our advantage in patients who have kind of chronic diarrhea, irritable bowel syndrome. We also see worsening of reflux. So there's more reflux when patients have underlying reflux. But usually what we see is an uptick in reflux at first, but then because patients lose weight and reflux is in part stimulated by weight gain, we see a decrease in reflux. Sometimes burping, and patients always say the same thing, like burping that tastes like sulfur, and then nausea. And there are many ways to get around this. There are medications that can help with nausea in the beginning. There are dietary changes we make. In terms of catastrophic side effects, there really are very few. So they recently found that there might be an increased risk of a nerve in the eye developing what's called ischemia. Very, very, very rare. Most of the eye problems we find are from patients who have really uncontrolled diabetes who improve their blood sugars too quickly. So most of that is not actually applicable to the vast majority of patients who are using these medications in this day and age. In rodents, so I would say if you are not a rat or a mouse, you don't have to worry about this. And then some patients are like, my husband thinks I'm a rodent, but like in general, I get that a lot for some reason. In general, if you're not a rodent, you don't have increased risk of medullary thyroid cancer. And I want to be very clear, having a history of a different type of thyroid cancer, like one of the much more common ones, papillary follicular, is not a contraindication. So if you don't have a history of medullary or a family history of medullary thyroid cancer, it's not contraindicated. If you're not a rodent, you're not at increased risk as far as we know.
I love the fact, I love the fact that she mentioned rodent, because as I said, I'm a lawyer. I do trial law. I've tried a number of high profile cases. You see Helen Mirren's beside me because she played me in a movie. And we call in our rats snitches. Okay, so we do have an intersection there, Dr. Messer. Rats and snitches.
Fair enough.
So I only mentioned the side effects. I was one of the lucky, I had no side effects, none, Zippo, and I had the worst. I have the worst acid reflux it was under control before I saw you because of a hiatal hernia, which a lot of people have. But I had none, Zippo, fabulous. Yeah. Okay, so
if you look at the clinical trials, honestly, it's like less than 30% of people have these side effects. They just get kind of overblown in the media.
Yeah,
that is
right.
Very real. Is if you lose weight rapidly, you're going to be at higher risk for a gallstone. So the gallbladder is up here in the right upper quadrant. And basically, if you're not eating a lot, the gallbladder isn't contracting. And we need those contractions because it helps break up any potential stones. That's one reason. And also because as you're losing weight, a lot of cholesterol is kind of fluxing through the gallbladder, putting patients at increased risk for stones. But my answer to that is if you are committed to weight loss, any modality of weight loss can increase the risk of gallstones. So you just have to sort of accept that slight increased risk.
Okay, so you have the slight increased risk, but there's so many benefits in addition to weight loss that we're seeing from these drugs. As a matter
I'm
of fact,
actually gonna have Amy go back a few slides because we're missing some really great slides here. Maybe even one further. I know this seems very. Oh, actually, let's go back. Yeah, I know this seems really busy, but I just want to kind of prove to people that it's so much more than just reducing the risk of diabetes and also making you more full. So starting at the top with the brain, we think that it's actually neuroprotective. It decreases inflammation in the brain, and we'll get to this later. We don't have the results of this new trial called EVOKE yet, but may decrease the risk of Alzheimer's, Parkinson's, heart circulation. So it definitely decreases inflammation. And we're seeing in trials decreased risk of heart failure, stroke, heart attack, death. In the pancreas, it may actually, beyond just telling the pancreas to produce more insulin when appropriate, it may actually improve the ability to produce insulin. So it helps with what are called beta cell survival. Beta cells are the cells that are so important for producing insulin. It helps break down fat. The number of advantages is just so startling. Decreases fatty liver. So that's the hepatosteatosis. And that's like just the beginning. So let's go to the next slide. Okay, so this is basically everything that I just said. I wanted to show it in another slide because I think it's so important. So this is the difference between the GLP-1s and the GIPs, and Linda asked about it before. So the additional advantages to the GIP are you see an improvement in insulin sensitivity. So insulin resistance is really the main issue with prediabetes, diabetes. So there's a direct effect on insulin sensitivity, fat metabolism, storage that you're not seeing with the GIPs. So I think that's kind of important to highlight.
So go back in just a second for people that missed the beginning. What is the difference in the GLPs and the GITs?
So the GLP-1s, that's like Ozempic, Wegovy, also the old one, Saxenda, and the GLP-1s plus GIP. It's not that they actually bind to the receptors and increase your body's GLP-1 and GIP. That would be like the Mounjaros and the Zepbounds. But they're both gut drugs. They're both gut hormones, and the drugs are about 97% identical to your body's own GLP-1 and GIP. So I would consider them quite natural hormones.
Okay, so we talked about the dosages, we talked about the side effects, but we talked most importantly about the side benefits, which I think that
Yeah.
doesn't get, but that the media tends to forget that, which you just
Yeah.
discussed. And I think you see that with people. I know people come to me because I tell everybody that I'm on Manjaro. I'm not hiding it. I'm not Lizzo. I don't want an allegation against me, especially being a lawyer. But when doctors start seeing that there's a borderline that you're pre-diabetic, does that ring a bell for any patients that do patients get seen by you? The doctor send them to you
Yeah.
because that's like a, hey, we're in trouble.
Yeah. So endocrinologists really typically hate even the distinction between pre-diabetes and diabetes. And some will argue that that shouldn't even be a term because it's the exact same disease process. It's all on a continuum. So to say, oh, when your blood sugars are X, you're not allowed to get this medication. And as soon as it's Y, you are, I think is pretty ridiculous. It's all the exact same thing. It's your body becoming resistant to insulin. As a result, the insulin levels are rising because whenever you're resistant to something, the body just produces more. All of that insulin is making you gain weight because insulin is what we call an anabolic hormone. It makes you gain weight just when you need to lose it. At the same time, it's causing this like storm of inflammation in your body. And so, yes, I mean, as soon as I see that somebody is becoming insulin resistant, or pre-diabetic, you can get into trouble at an endocrine meeting for even using that term. But as soon as somebody's becoming pre-diabetic, I start to think about these medications.
That's really fascinating to me. Now, are they a quick fix in the sense of, do you still need to have good nutrition? Do you still need to have exercise? That's A and B. And then I'm going to give you a C, which is a little off topic. Some people say they're scared of the needle. Now, I found the needle in the Mounjaro fabulous, but let's talk about the first two, nutrition and exercise, and then talk to us about people that may be scared because they're scared of an injection.
Okay, so nutrition first. So first, there are lots of things that you need to do to prevent side effects. So maybe not you, but most people need to stay super hydrated, be on a high fiber diet. Also, to prevent yourself from losing too much muscle, you have to be getting enough protein in your diet, like a certain number of grams per meal, 25, 30 grams of protein per meal. But yes, you have to do your part because eventually we may want to get you off these medications. It's not always possible, so I don't like to overpromise. And so much of eating is sort of emotionally driven, right? Depression, anxiety, binge eating. Very often it's easier said than done. But I like to have my patients, when necessary, working with a psychologist, doing cognitive behavioral therapy, because sometimes it's not just about the dietitian telling them what to do. But then I also have the dietitian helping them figure out, okay, you are going to be going out every night. You're going to be ordering in every night. Maybe that's your pattern, but let's pick out what you're going to eat in advance so we can get you on sort of a high protein, low carb, high fiber diet, lots of monounsaturated fats. So she'll help my patients. She's wonderful. Her name is Jean Hanks, and she'll help my patients figure out what they should be eating. It is very easy on these medications to have an awful diet and still lose weight, but it's not helping anyone because then you're going to be, thin on the outside, unhealthy in the inside. So we're always trying to make sure that our patients are following healthy diets. We're watching their labs. We really want balanced diets, good old fashioned balanced diets. In terms of exercise, yes, you're going to be losing muscle. We all know that. So we're having patients do a combination of just activity, but non-exercise activity like walking, and then aerobic activity, high interval training, and strength training all at the same time. And we have a trainer in the office who's helping our patients achieve all of that. So super important. Okay. And now we have
now the psychological, the needle.
Yeah,
people are afraid
exactly.
of an injection.
So I will say, everybody's like, when is the oral coming out? There is an oral version, but it's only FDA approved for diabetes, and that's called Rybelsus. It's the exact same thing as Ozempic or Wegovy. It's just super expensive because it's not covered by insurance. We have little tricks. We'll order it from Canada. I have lots of samples for starting doses, and we will have oral doses in the future. Everybody prefers something different. Some patients like the auto injector, and for some patients, having a needle come and they don't know when it's coming is scary. So some of those patients prefer to have a needle where you have to actually place it under your skin. I'd say almost everybody within a week or two gets adjusted to it. I like to tell people that the needle is the size of 2 human hairs, that it's almost painless. If somebody's really scared, I will sacrifice myself and I'll use not a real pen, but I'll use a sample, a demo, and I'll inject and I'll say, see, I barely felt it. Because that makes them feel better. If their doctor can do it and not even feel any pain, that makes them feel better. Icing the skin will certainly help. If patient's terrified, we can give some like EMLA cream, which is a little bit of lidocaine so that they really don't feel it. There are even things called shot blockers. So it's like this little plastic thing you can get on Amazon. It has tiny little rubber points and you place it on the skin and it stimulates certain nerve fibers so that you can't feel the shot go in. So shot blockers work great, but most people get past it pretty quickly.
I found the needle fabulous, quite frankly. It's so easy to use and you can also travel with it generally. The one that is in the packaging, not the ones that maybe you get from the compounding pharmacy,
Right,
but you can
right.
travel. That's one of the things I found, that the to have the original was great because I could travel with it and it could be room temperature, I think, for 21 days and all. Are there new drugs on the horizon that are going to have 4-semaglutides or are going to work on the fatty liver better? In other words,
Well,
are Ozempic and the brand names we're hearing about now and Mounjaro, are they going to be obsolete soon?
I don't know soon. I'm thinking about 2026 based on everything that I'm reading. Yeah, so there's going to be a triple hormone therapy called retatrutide. It's a mouthful. I'm sure there will be more. I'm so sure there'll be quadruple hormone therapy. I also think that there are going to be plant-based therapies in not too long. Fascinating research going on with AI, looking at literally millions of plants to figure out which of those plants have incretins in them and have fewer side effects and might be able to eventually replace these medications, be oral with very few side effects. So there's a lot coming down the pipeline, but I don't think it's going to be in 2025. I think we have to wait like at least another year and a half.
But that's why you need to work with an endocrinologist like Dr. Messer, because she'll know about these and she'll know what's best for you. I mean, as I said, when I went to see her, she said, I think Mounjaro is going to be best for you because it has the additional semaglutide, should I say GLP or
The
semaglutide,
additional incretin, yeah,
an
GIP. And
additional
by the way, I just
incretin.
want to say I'm not paying her. She's not my PR agent, but
No,
really
no,
nice.
I'm not. But I love my doctors, and again, I hope she's on by now, by Dr. Wendy Zychek, who sent me to you. Because I think you've been trying to do this. We're at the time that now you have to do it because you have high blood, your blood pressure starting to go up. We didn't talk about that. That's another side benefit, isn't it? That you can
Yeah.
bring your blood pressure down, right?
Let's actually, can we advance the slide? Okay. So let's do this slide first. So there are so many potential new benefits. All of this is off label. You can't say, okay, I have liver dysfunction, so please cover it. Like I have fatty liver, so it should be covered by my insurance. But these are all the potential uses. So weight loss, we know. Heart, I think most people know now. It's not just from the weight loss. In head-to-head trials, when people are losing weight from other modalities, we don't see the same decrease in cardiovascular events. So it's something about the fact that it's anti-inflammatory. It just melts away fatty liver. It's absolutely incredible to watch it change. We're now seeing that it may protect the kidneys. We've known for a while that it could help with rheumatoid arthritis because that's autoimmune and responds to decreased inflammation, but we're now showing that it decreases osteoarthritis, which the whole population has at a certain age. Dementia, Alzheimer's, Parkinson's, even MS are places for research. All the research is ongoing, but the underlying etiology, the common link is inflammation. Sleep apnea for sure, probably because of the weight loss, but maybe because it's anti-inflammatory. I do want to hit on depression because I get questions every day, including today. Is my medication causing me to feel depressed? The European Medicines Agency reported that there were increased suicide attempts, and the answer is absolutely not. In all of the prospective, randomized controlled trials, there's actually a decreased risk of depression, probably because of an increase in dopamine. And we see that more with tirzepatide than semaglutide. And then addiction, that's probably my favorite. So also, I don't want to seem like I'm so prescient here, but I was using this for alcohol and smoking and any other addiction, any compulsive behaviors a long time ago. Sex, gambling, you name it. It's because that same nucleus in the hypothalamus that increases that sense of satiety helps with addictive behavior. So I think it's a very exciting time for these drugs. And it says GLP-1, but it should say GLP-1, GIP, glucagon receptor, like all of these incretins, they all have the same kind of effects.
Right. And again, I'm going to repeat that you need to work with somebody like a board certified endocrinologist like Dr. Messer, who knows what she's doing to be able to pick all this out. Because you see, it's not just like, you read about the Kardashians and you say, okay, I want to be on that. But for those who are watching now and aren't on the drug and aren't, they're not sure whether they want to see you or see another doctor to help them. I know somebody that is on Topiramax, which is I guess a drug mostly used in psychiatry, I think, or if
Actually, we
you have
mostly use it for migraines.
migraines.
Yeah.
Okay. Because they want to lose weight. And is that like a stepping stone? Is that something that you can work with the people and say,
Yeah,
look, I don't want to be on one of these now?
absolutely. We have so many other medications. The problem is a lot of those medications have other side effects that are less beneficial. So Topamax or Topiramate is a great medication, but in somebody like Linda, it would be a terrible idea because it can cause word retrieval issues. She needs to be on her game. So, if you're a high powered, if you're Linda, you don't necessarily want to go on it. Also, you can see a lot of patients get tingling in their fingers and toes, which is kind of unpleasant. You can see an uptick in anxiety and depression. So there are reasons that we might not want to do that. We have phentermine, but we can't give phentermine to anybody with high blood pressure. We can't give it to anybody really with too much anxiety or insomnia. I mean, there's so many other options. There's Wellbutrin, but it can raise the seizure risk. It can cause anxiety. There's naltrexone, which is actually pretty well tolerated, but not that effective. So far and away, these are the best medications. But yes, in somebody who has a contraindication to these, there are plenty of other medications that we can try, and we do try all the time.
Okay, so I think I hit on most of the items that most people are interested in. Of course, we're superficial and every patient's different. Listen to the patients, what Dr. Messer says. Go to her website, you'll see that. But is there anything else that everyone who's watching should know about these medications?
Well, I think that they've gotten a bad rap. Honestly, mostly I would just say the media does a really good job presenting the downside, and it's not as sexy to talk about the upside. Like this slide would never make it to the news. But you don't have to have uncontrolled diabetes. You don't have to be extremely overweight to consider these medications. There's so many considerations. Nobody should be judging you for being on them. I think it's something that we should talk about regularly with absolutely no stigma.
And
So,
that's why I'm here talking about it. That's why I'm interviewing you, because I am your patient, because I am high profile, because I have anchored TV shows and do TV shows, and I want people to know that no stigma. It's fabulous. It helps you. It's healthy for you. It's healthy. It's just wonderful. And the more you talk about it, the more you find that the person next to you is on one of the medications also. Maybe not, maybe they're in New Jersey, maybe they're in California. Luckily, they're not in New York. I wish they were to see you. But I think that opens us up to questions now, because I know all of you have been watching, the attendees have been watching, and I think that we should be open to questions. If Dr. Messers, if you've got her now. Okay. All right, here we go. First one. What vitamins should we be taking if we're on one of these drugs, if any?
okay. This is the answer is it's bespoke. We really have to draw your labs. If everybody's taking B12 and folate, you just urinate it out. If your levels are low, then it can be helpful. I never really see vitamin deficiencies as a result of these medications. But every single patient, I'm always monitoring their protein, their iron, their B12, their folate, their vitamin D. In fact, what's interesting is that vitamin D usually improves with these medications because vitamin D is what's called a fat soluble vitamin. And so as your adipose tissue or fat goes down, the vitamin D goes up. So you do not have to just start vitamins because you're taking these medications.
Well, that's really interesting about the vitamin D, because you see that a lot of times, your vitamin D is low. So in addition to that, we have another great question. How much exercise should a patient be doing while on these medications?
Yeah. So I usually say, I mean, you don't have to do 8 to 10,000 steps a day, but something like that. So that's not really considered exercise. That's considered activity. And then 30 minutes, 3 times a week of real exercise. And the way I define real exercise is you have to shower afterwards, or you're comfortable enough that you can speak comfortably, but it would be hard for you to sing a song, right? Because you're actually exercising your heart. And then in terms of strength training, I'm not asking for more than 10 minutes 3 times a week.
Okay. And you should work with somebody, I think, who puts you on the right track with that, but that's my
Yeah.
own personal
Being
opinion.
mindful. I mean, everybody has injuries, and it's good to have somebody who actually knows what they're doing,
Right.
so that you don't injure yourself or start too quickly.
Okay. So what are the long-term effects? Do we know yet?
Yeah, so we only have data from 2005. We have not seen an increased risk of pancreatic cancer or anything scary. We have not seen an increased signaling of thyroid cancer, thank God. We think that the long-term effects are all those good effects, right? You have decreased inflammation, and that is the key to longevity, right? We should not have an inflamed body. You can't see it, you can't feel it, but it's there and it's doing harm. So we think that the long-term effects are all basically good effects.
Dr. Messer, we have a number of questions here. When do you know if you should come off the medication?
Yeah. So when you've really changed your lifestyle, and this is controversial because there are some endocrinologists who say, once you start it, you are on it forever. I don't feel that way. So I don't want to toot my own horn. But the reason I started my center, which has all these other practitioners in it, is so that there is a hope that you can come off the medication. I want you to be able to get off the medication if that's your goal. And so the patients who had binge eating tendencies, let's say, and they've worked with a therapist and they are no longer binge eating, patients who were not exercising who now are exercising, or were eating fast food all the time and are not doing that, I do try to taper off the medication and see if they can maintain the weight loss. And I would say many of them can, and certainly not all of them can. And that's okay.
That's fine.
But the
I
answer
mean,
is
I'll
it
be
takes
happy to be
forever.
on it. I'll be happy to be your patient for my
Yeah,
whole life.
plenty of patients are happy to take it for life, and I'm happy to give it for life.
And so along with the eating right and the exercise while you're on these, how much protein should we be
Yeah.
taking per day?
Yeah, so some people say 100 grams of protein per day. I think if you're doing 25 per meal, that's more than enough. I see patients trying so hard to have like 8 pieces of chicken a day. I think that's excessive. We can watch your albumin levels, which are markers of your protein. I have never seen somebody's albumin actually drop low. And we can also watch using in-body testing, which is like you hold your hands on this little machine and it tells you how much muscle you have. We can watch the muscle and we can let you know if we feel like you need more protein or more exercise. Usually we don't see a huge amount of muscle loss, despite what the media likes to say.
Okay, so along the line of the previous question, somebody asked, let's say you lose 40 pounds and you want to get off the medication. Will you gain the weight back? Have you had the studies yet to see whether or not that weight is going to be gained back, even if you maintain the same eating and exercise regimen?
If you're able to maintain the exact same eating and exercise, I can tell you the proof. I mean, I've seen this so many times. You can maintain the weight loss. It's just that all the cravings come back, the hunger comes back. So the vast majority of patients have trouble doing that. But I 100% have patients who are tracking and, using calorie counters, seeing my dietitian, who are able to maintain the weight loss.
Right. So you mentioned acid reflux as well, the side effect. I had acid reflux before I saw you, and Dr. Zaitchik had it under control with various modalities. What do you think in terms of patients who see you who just get the acid reflux from, or the increased acid reflux from one of the GLPs?
Yeah.
What is your best treatment? What is the
So my
treatment
best
you
treatment,
recommend?
I mean, there are a lot of things. First of all, avoiding the triggers, right? So easier said than done, cutting back on caffeine and chocolate and acidic foods like tomatoes and all of the fun stuff, alcohol, chocolate, but also not eating within 2 hours of bedtime, because if you lie down pretty soon after eating, you're going to have more reflux. And then trying to sleep, on a slight angle. Sometimes I have patients have, the 2-pillow method. And then of course we'll use acid blockers, at least in the beginning, because having reflux isn't entirely benign. Chronic reflux can increase the risk of Barrett's esophagus, which is a precancerous condition. So I do take it seriously, and I always work with the gastros. It's important that I always know who your whole team is. So I love one proton pump inhibitor as much as the next. So we can use, there are two different ways. You can have proton pump inhibitors and something called H2 blockers, and they're both great at decreasing acid. Sometimes we'll combine them. Sometimes we'll just use one of them. But yeah, that's what we basically do. And if patients have hiatal hernias, sometimes we'll fix them, because it's pretty hard
Right.
to avoid reflux if you have a severe hiatal hernia.
Oh, that's me. Okay, well, we're doing our best here.
We're doing our best,
We're
right?
doing our best. So how much fiber should you be consuming if you're on one of these medications?
About 25 grams a day. I mean, we don't need to go too crazy.
Okay, I know you said that before, but I think this was a specific question specifically about fiber.
Yeah.
And Somebody else wants to know, why do people lose muscle mass on these medications? Is it because they're
Yeah.
just not exercising, or are they losing muscle mass because
They're
they're just losing
actually
weight?
losing muscle mass, but the thing is, anybody who's losing weight and effectively loses muscle mass. And I've yet to see a study really proving that these medications break down muscle in some way. They just are so effective, and so you lose muscle.
Wow. Okay. And I just as a point, I bought it. I've always I've had a Withing scale, so I bought the most recent Withing scale, and you can kind of see a little bit of what happens on your own, and then call your doctor if you think you're losing too much. But doctors have different approaches, Dr. Messer. One of the people have been on Zepbound, and it goes the increase of the dosages every 4 or 5 months. Now, I know you don't want to comment on what other doctors do, but apparently the patient feels that she's not losing enough weight. She should work with her doctor differently. Do you think dosages are more effective if they go up quicker, slower, just as a general rule?
I mean, if a patient can tolerate the medication and is not at their ideal body weight, it really should be increased monthly. There's absolutely no reason to go slowly.
Okay.
Yeah, as long as and also we want them to be obviously exercising at the same time and following a healthy diet with protein. But I haven't seen any studies showing that you should wait 3 months before increasing the dose. That just would probably lead to frustration.
Yeah, that's what I think what one of our attendees is feeling. Another
Yeah,
one who also has some frustration is on Manjaro, doesn't feel that their hunger or binge impulses have changed. So,
right.
and how long
Yeah.
does it take to that to change? Is that something that happens quickly
Okay.
or not?
So hunger and binge are sort of different. It definitely, I mean, the vast majority of people, 2.5 milligrams works for hunger. Sometimes people have to go up to 5 or 7.5. I've even had some rarely patients say that they had to go up to 10. It always works eventually. So the person should take heart in the fact that like it will eventually work. It does work for binge eating, but if a patient, I mean, the person might be using the term binging lightly, but when patients really have a binge eating disorder, you really have to treat that. I would say the only patients who fail these medications, fail to lose weight, are patients with untreated binge eating disorders. And because they'll eat even if they're not hungry, they'll eat even if they have a feeling of satiety. So I like to, I mean, as an endocrinologist, I feel it's my responsibility to treat the binge eating. So I will give Vyvanse, I will give other stimulants and set the patient up with therapy for their binge eating, because I don't think you can really be successful unless you're treating that.
Well, and that's one of the things about your center that I found fabulous, and whoever you go to, is that you have access to psychologists, mental health professionals to try to deal with whatever may be the underlying reasons for your eating,
Yeah.
in case it's not just that you're getting older and
Right.
lose some of the
I
hormones.
mean,
All right, so
yeah.
what
So
about
just
normal weight?
one more word about binge
Yeah.
eating. We see a very, very close association between ADD, ADHD, and binge eating. So we think that the reason people are binge eating is to use food to increase dopamine. And we know that with ADD, ADHD, there's a deficiency of dopamine. And so by giving back, by raising up the dopamine with medications like Vyvanse, patients don't feel the need to use food for that purpose. And then it really allows the incretins to be much more successful. So I just wanted to throw that out there for anybody who's struggling with that issue.
So what about people who are at the normal weight on the weight charts, who seem to be at the actual weight? You mentioned that there's reasons to use these drugs for other reasons, such as addiction or your well-being. Is there a risk for hypoglycemia, someone
Oh,
asks?
so I think maybe the person missed one of the earlier slides. If your blood sugars are not high, incretins do not tell the pancreas to produce insulin. So we're using this on a lot of patients who are overweight and have normal blood sugars. And we can also use it on patients who are normal weight and have normal blood sugars without a risk of low blood sugar.
And getting off these drugs, what we talked about earlier, but do you think it's going to be a choice of the patient, or will is it the choice of the doctor?
Well, it's
To me,
always
I
the
will
choice
answer
of
is
the
it,
patient.
but that's what I
I
would
mean,
answer, right?
yeah, I'm always working with my patient and their preferences. And sometimes we have patients who stop it for a year or two and then come back, and that's okay too.
So there's no standard as long as they're working with a doctor. I heard
Yeah.
somebody, I was in a side conversation at a next table restaurant. I heard somebody saying they were getting black market Ozempic And I was like, oh, I don't want to hear this conversation as a lawyer. But let's go back to something that you mentioned earlier. You mentioned EVOQ, EVOOQ.
Oh, the Evoke trial? Yeah.
Yeah, can you say more
It's
about
not a
this?
medication, it's a trial. Sorry?
Okay, somebody wants to know if you could talk about that a little bit more, what you were
Oh,
talking about.
sure. So right now we just have data, I think, from the phase 2 Evoke trial. It's looking at whether these medications can be used to decrease the rate or slow down the rate of progression from mild cognitive impairment to full-blown Alzheimer's. We're not going to have results for a while. I feel like personally, given the great side effect profile from these medications, I have a low threshold for using them to prevent a decline in cognition, just because you can't afford to wait a few years until the trial comes out if you're already having cognitive decline, and there's so few side effects from the medication. But yeah, it's going to be probably like 2026 when we have results from the phase 3 trial, which is really the trial you need to get something FDA approved for a certain indication.
All right, but as you said, you're seeing results in that now anyhow. In terms of what's going to be covered by insurance, everyone's
Yeah.
insurance is different, but these drugs now are so widely used, the benefits are so great. Do you foresee in the future that either the price is going to decrease or that insurance and Medicare is going to cover all of
Yeah.
these drugs?
Yeah, I mean, I think it's a travesty, honestly, that Medicare and Medicaid are not covering these medications for weight loss. You know, they're covering for diabetes, but not for weight loss. Yes, I think that the indications are going to mushroom. I think thank goodness we live in a capitalist society where there's going to be so much competition. It's going to drive all the prices down. You're going to have all these meds going off patent. I think that there will be a time when this is so affordable. It's just, it's a little uncomfortable at the moment because there's so many people who can benefit from it and can't get it covered and can't afford it.
Right. I know that some of the state insurance programs, like New Jersey, if you're on the state insurance program because you're under a certain level, it doesn't cover no matter what. It just doesn't cover any of the medications.
Yeah.
Do you think that ocular migraines are caused a side effect of any of these medications, doctor?
Huh. I don't think so, unless dehydration and hunger trigger your migraines. But that certainly could be a trigger for some patients. But I wouldn't say
Okay.
it's directly, as an indirect effect.
Okay, I think somebody had that question about that. So if you want to start, because you've watched this program and they're so impressed with you and they're so impressed with the Weight Watchers pilot program, do you start from, where do you start from? Do you start from going to your own doctor like I did, who recommends you, or do you just say, okay, I'm going to pick up the phone and call Dr. Messer?
Or any endocrinologist. Yeah, usually, I mean, some primary care physicians are comfortable with this, most are not, because it's pretty easy to prescribe it, and then it's a lot harder to answer questions when things go wrong. So yeah, usually it's an endocrinologist. Just call your local endocrinologist and get on the wait list.
Get on the way.
Yeah.
Yeah, but you're hard. Sometimes your wait list is
I don't mean my wait
long.
list. I didn't mean to be obnoxious. I mean endocrinologists in general are very oversubscribed.
And this hydrating on water. You mentioned that we should be drinking water. I mean,
Yeah.
I do have one
Water
vice.
and
I will confess to you. I drink the mango tea from Dunkin' Donuts. I still have one vice on this. Because I kind of bring it
yeah.
into the courtroom. But should we be drinking water? Should we have powders with electrolytes?
Yeah,
What
I
else?
do think electrolytes are important because sometimes patients' blood pressure drops a little bit on this. They're eating so little, drinking so little, they're so thin. So yes, I like to add Nuun little tablets, NUUN tablets to water. But yeah, any type of, you don't want to have a high sugar electrolyte drink like a sports drink, but any kind of sugar-free drink is great with electrolytes.
Okay, so this gets me to women over 40. One of our participants asked, what about if you're perimenopausal, you're menopausal, you're postmenopausal, and there's a tougher time of losing weight? Do you see these drugs being more important for different age groups?
Yeah. I think that they're super important in the perimenopausal years. We know that as estrogen is starting to drop off, we see more insulin resistance. We see that incretin resistance goes hand in hand with estrogen, with insulin resistance. So you really can't see a patient who is becoming insulin resistant and then doesn't also have incretin resistance. We know that in those perimenopausal years, the average weight gain is 10 pounds. Even without all of that theory behind it, I just feel like menopause is hard enough without gaining weight. I have a very low threshold for prescribing it. Women tend, a little hormone replacement therapy when appropriate combined with an incretin makes such a difference in those years, which can be pretty difficult anyway. But yes, it's definitely tougher to lose weight because of the drop in estrogen. You definitely have, weight starts settling in the midsection. And these medications, especially the GIPs that have a direct effect on fat burning, really help with that.
That's great. Now, you mentioned the addiction. I think that was so important because we know that addiction is a real issue in our society. And someone wants to know how could you explain a little bit more of how the incretins help in the addiction? And do you automatically need to see a therapist, a psychiatrist along with that, or any other mental health professional along with if you're going to treat some addiction with these medicines?
Honestly, I don't know how to describe it more than it works in the brain, in the area of the brain that causes compulsive activity, and it tamps that down. It's like a receptor blocker there. So, I mean, I don't think we know much more about it. I mean, there are theories, increases in serotonin and dopamine and things like that, but I don't think we really know. I don't think that patients necessarily need to see psychiatrists because sometimes the medication alone sort of takes care of it. Psychiatry is never a bad idea, I suppose, if there's also addiction, on top of the addiction, there's also anxiety and depression and OCD and all of that. I mean, certainly other medications can help. But I've had plenty of patients where I have not insisted that they see a psychiatrist.
Okay, so some people get, as we've heard in the media and one of our participants here, gets nauseated as a result of being on Mounjaro. It's something that I didn't have, but a side effect. But are there specific medicines that you use to deal with the nausea so that they don't feel like they have to get off the GLP or whatever drug that they're on?
Yeah. It's a really good question. So Zofran is the medication of choice in general because it has so few interactions with other medications, including psych meds. Sometimes we use Dramamine, sometimes we use Tums that can help with the nausea. Most of the time, and this is not a great answer, it's a question of changing diet. Because if you're drinking a lot on these medications, or if you're overeating, or if you're having really fatty foods, or again, eating too close to bedtime, or if you're not eating anything, just like morning sickness, you can get more nausea. There are, of course, lots of other prescription strength medications for nausea. We tend to shy away from them, but we will give them in the correct patient, especially if we've spoken to the psychiatrist and made sure that there are no interactions with their other medications.
Okay, so I'm going to join these next two messages or next two questions together because they have to do with groups. But this participant's pilot program, her husband has been on medication. She's been on the medication. Is there any data, because he lost a lot more weight than she did, on whether or not that they work differently on men and women, whether they work better versus men versus women, and should teenagers be on them if indeed the teenagers are overweight?
I'll just say in general, it's an unfair world. Men do lose weight more easily. So it's really your percent muscle that controls your metabolism. And men in general, patients who are assigned to male identity at birth, whatever we call it, have a higher percentage of muscle in general. And so they do tend to lose weight a little bit more easily. I don't really know of any studies, although it would be interesting to look into them, where we see that there's so much higher percentage of weight loss with men than women on these medications in particular. But yeah, I would say that one thing about the muscle composition in men versus women. In terms of teenagers, so these have been approved now for 12 and up. So yes, I think that those formative years, high school years, middle school years, can be really difficult, and patients can be left with like lasting issues, when they were bullied or teased during those years. And I think that if we can help patients avoid that, that's wonderful. Like, what a gift we're giving. And I've had patients who have already had fatty liver and sleep apnea and are not exercising and, just addicted to screens at a young age. And we can really reverse all that and create much happier, confident young kids. Now, I understand, especially for women, you're going to have to come off of them if you decide that you want to become pregnant. I understand it can interfere with birth control, which can be an issue for teenage women. But there's also a lot of upside. So yes, I don't have an issue Now, in my practice, we have a pediatric endocrinologist who does a lot of our work with our teens because she's so sensitive to the issues and the increased risk of eating disorders and all of that. And so I'm very grateful to have her so that I'm not taking care of teenagers on my own.
And I know you have pretty much a hard out in about a minute or so. So I want to give you this question from somebody, and then we do have 28 or 29 more questions. So I know that if
Oh,
you
wow.
put your email into, send it to Amy Peck of Peoplehood, Dr. Messer will try to answer your questions in the future. But I think this is a very good one to end on. Will this drug help high blood pressure, or will it cause high blood pressure?
This
And
is
can
like
you
so
talk
easy.
about,
It lowers blood
yeah, and can
pressure.
you lowers it? No
Lowers
problem.
it,
And can you
hands
talk,
down. No, yeah, no discussion, not controversial.
and can you talk about compounding pharmacies?
Sure.
Can people use compounding pharmacies? Are they
Not
safe if they
all
can't
compounding
get?
pharmacies. You do have to do your research. So they're not all created alike. So some compounding pharmacies were actually just putting sugar in water and selling it. So that's probably not very safe to inject. Some compounding pharmacies were just using dyes, like adding pink dye to water. So there are obviously, there are lots of scams out there, and there are lots that probably are not safe. So you need to find a compounding pharmacy that is accredited and ideally has something called 503B accreditation. So that's like the most stringent form of accreditation. So if you can find that, I think it's probably safe, not FDA approved, but safe to take. I do worry now that they're saying that there are no shortages anymore, which I think is wishful thinking, that the FDA is no longer going to allow compounding pharmacies. But well, you can speak to this, the legal aspects of it. There are already lawsuits from the compounding pharmacies, blah, blah, blah. It's probably going to go on for years. And by the time these lawsuits are finished, probably it'll be easy to get these medications.
Right. I think it's going to go on for a long time. I know people, I know some people are going to Florida. They're calling their friends in Florida to get compounding pharmacies to do some of these drugs. I think that there's such a desire to be on these drugs because of the benefits that you mentioned. Let's finish on a high note about how great they are, how effective they are and all. And you can hear my dog. My dog is saying, I have to go outside, Mom. But again, put your email into the chat, send it to Amy Peck. I think Amy, if I don't know if Amy can get back on, even if we don't see her, send your email to her.
Well,
and
actually,
then
I'll make it even better. I'll put my office manager's email. You can
Okay, that's
just
even
send
better.
the questions directly to her. If I get the same questions a few times, I'll just answer them together. But I'm happy to try to answer all the questions.
Right. That's I think I should give it to you, the floor to you for one last thing to say, Dr. Messick, before Amy gets on and closes us up.
Oh, do I
Giving
have
you
one last thing to say?
Yes, you had the floor
Oh,
as to the one final thing you want
my
to
final
say
thing
to
is
everyone,
just,
because the participants are so involved here. One final thing you want to say
it's
about these
just
medications.
very exciting to see so many people on this call. I really appreciate that everybody took time out of their busy schedules. And I'm so excited about these medications, the future of these medications, and I just want to be here as a resource to anybody who has questions. So please don't hesitate to reach out. I'm really not trying to push my own wares. See your local endocrinologist, but take advantage of this incredible new class of medications.
And I'm going to push your wares for you because she's a fabulous doctor. I'm a result of it, a year and a half, 17 months of it. And she's fabulous. She's wonderful. And a shout out to my own doctor, Dr. Wendy Zychek, who
Hi, Wendy.
got me to you. Hi, Wendy. All right, Amy, I'm turning it back over to Peoplehood.
Thank you so much. We want to send a huge thank you and gratitude to Dr. Messer. This was amazing. And Linda, thank you so much. And we got so many requests for your website. Could you just tell people what it is, Dr. Messer, so they can go to it?
Oh, sure. Actually, can we put up the slide? I put up a slide because Linda told me to.
Oh,
with
yes.
that information.
That now. Hold on.
Well, by Messer.
I was like,
put that slide
you're going to
up.
want to see that? She said,
yes,
absolutely.
Yes, absolutely. I think it should be is it number 1? Or is it the end?
It's at the very end. Yeah.
These are all the things we try to talk about, by the way.
You might have an old version. Okay. So it is www.wellbymesser.com. I can put it here.
Okay. I'm
It's
going to
pretty
put
easy.
that. Yeah. I'm going to put it in the chat for everybody.
I knew they'd want to see your doctor. I knew they'd want to see your website and read all about you and all, because I think this chat just showed how important you are in medicine to these drugs, telling us all about the indication of these drugs, and Peoplehood and the pilot program they're doing with Weight Watchers is just fabulous. So thank you very much, Amy.
Thank
And
you. Have a
Julie,
great night.
Julie, who's not on.
She's watching.
Thank you,
Okay.
Julie, wherever
All
you
right.
are.
Thank you both. Everybody have a great night. Thank you
Thanks
again.
so much.
Thanks, everybody.
Bye.